Hello, everybody. We'll do a quick review on this case study. Hospital X was noted to have an extended length of stay. Further investigation revealed that the core causative agent was related to case management and discharge planning. There were recommendations that came to fruition, and we correlated these to leadership theory application. I'm going to focus on the reinforcement theory and the expectancy theory in relation to IDT rounds as our core recommendation for this issue at hand. The reinforcement theory emphasizes the role of rewards and punishments in shaping behavior. In the context of IDT rounds, this theory can guide team behavior and patient care strategies by reinforcing desirable actions that reduce extended length of stay. The positive reinforcement is a key component of this. We need to reward team members for proactive problem solving and timely discharge planning. Example of this is recognizing a case manager for successfully coordinating a complex discharge within a specific time frame during the team's meeting. Negative reinforcement is also a key component. Removing barriers that impede efficient care processes is what this looks like. For example, reducing unnecessary administrative approvals that delay discharges can encourage more timely decision-making. The punishment aspect of the reinforcement theory must be utilized sparingly. Discouraging practices that contribute to length of stay, such as delayed documentation or incomplete care coordination. This is example. Here's an example of this. Implementing accountability measures for delays in daily patient progress reviews. A continuous feedback loop needs to be implemented with frequent feedback during the IDT rounds on what behaviors and interventions are contributing to improved length of stay metrics. Sharing a dashboard during IDT meetings that highlights trends in length of stay reduction and team performance is a great example of this. Switching gears into the expectancy theory, we understand that there are three key components: expectancy, instrumentality, and valence. Expectancy is effort equals performance. Ensuring that team members feel confident that their efforts will lead to meaningful contributions in reducing length of stay. Training staff on streamlined discharge planning processes and equipping them with tools like electronic checklists to facilitate smoother care transitions is an example of this. Instrumentality, performance will equal outcomes, demonstrating the link between team actions during IDT rounds and the overall impact of length of stay metrics, showing how accurate daily updates on patient status during IDT rounds result in fewer discharge delays. Valence is the value of outcomes, highlighting the importance of reducing length of stay not only for organizational efficiency, but also for patient outcomes and satisfaction. Sharing patient success stories during rounds where reduced length of stay contributed to faster recovery or fewer hospital-acquired complications, as an example. Integrating both of these into IDT rounds means there needs to be a structured agenda with rewards. Use the reinforcement theory to structure IDT meetings by rewarding teams that meet discharge planning goals or propose innovative solutions. Clear goals and impact metrics need to be implemented using the expectancy theory. Set clear goals for length of stay reduction, communicate the value of achieving these goals, and provide feedback on progress. Cross-functional training, reinforce effective behaviors by offering training programs that are role-specific and empower team members and enhance their belief in their ability to influence outcomes, because they truly do influence these outcomes. The decision-making needs to be data-driven. As stated earlier, providing a dashboard during the IDT rounds showing the length of stay trends will reinforce positive behaviors through recognition and making the impact collective and effort tangible. And with this recommendation of IDT rounds comes further recommendations. We need to ensure that there are not any secondary or tertiary components contributing to extended length of stay. And we need to ensure that there are streamlined admission and discharge processes in place. Standardized admission protocols, utilizing evidence-based guidelines for diagnosis and treatment to ensure timely initiating care is a great example of how this can be accomplished. We need to be proactive in our discharge planning. Discharge happens at admission. Involving a multidisciplinary team into the team component of it will address potential barriers and get the patient out quicker. Provide clear discharge criteria and timelines so that case management and discharge planning are able to do their job. It's huge on the provider's part. Clinical pathways should be clinical pathways should be developed, and they should be condition specific to standardized care. reduce variability, and expedite treatment. Example of this is the enhanced recovery after surgery, or the ERAS. Utilizing this protocol will accelerate post-surgical recovery and discharge. Thank you.